Hello everybody and welcome. I'm sorry for the delay in getting started this evening. We're just getting some technical things right. So I'll let you all arrive and get settled into our webinar this evening, which is on leadership and quality improvement. We have our question and answer box open and our chat box open, so feel free to get started with the chat box just while we let everybody settle into the meeting. Okay, so just to do a quick introduction, my name is Sarah Luty. I am a GP up in the west of Scotland, which is, I think, a little bit less stormy than down south for the first time in a long time. I'm a partner in practice in Inverclyde and I work for NHS Scotland in quality improvement and patient safety, and I'm currently doing a project with the RCGP in it's called the Quick Project, where we are doing some webinars and a workshop coming up very soon on quality improvement. And we are also running a series of webinars, of which this is our 5th. And I'm going to introduce you to our co-host for this evening, Joanna. Do you want to say hello?
Well, hello everybody. Thanks so much for joining us. I'm Joanna Bircher. I'm a GP in Stalybridge, which is part of Greater Manchester. And I'm the clinical director of the Greater Manchester GP Excellence Programme. I've had an interest in both leadership and quality improvement for a number of years now, and achieved a master's in leadership and quality improvement a few years ago, funded by Health Foundation. And on the back of that, have helped the college develop their quality improvement resources, and recently co-authored a book on leadership in primary care. So I'm really happy to share any nuggets that I've learned over the years with all of you this evening.
And just to give a plug for this book, it is the most readable book on leadership, I think, that there is. It's not difficult, and it's really accessible for GPs and for GP trainees. So we're just going to get started with a little bit of interaction with you guys, and I'm going to share my screen just now and go to, or actually, Joanna, can we have the Menti slide up? So those of you who have used this before, if you've come to any of our other webinars, and this is just a way to make sure that we tailor the content of what we're going to talk about to things that suit our audience. And Nina's just asked me to put the title of the book. Joanna, can you pop that into the chat box for us? And we'll get you to go on to Menti, and you should see our first question for those of you that have found it. So with Menti, the question that we're going to ask, and Joanna, if you just give me a wee nod, if you can see this slide, is that there? Perfect. We will be going back and forth from Menti to the other screen. But what I'd like to do is to just type away with what you find hard about leadership and quality improvement. Make sure that when we're talking about this as we go through it, we can make sure that we answer your questions. Okay. Have we managed to go on to Menti? Any problems, just put it in the chat box and we can try and help. Okay, so we've got somebody with time, a very big one for time. Now, I don't know if this is suggesting that only partners are allowed. But that's an interesting time and capacity. These come up a lot. Well, one for you here, Joanna. Motivating other people, finding time. And we've got a little bit in the chat box here as well, Joanna, that we can add to, which is about what can a trainee do to complete this capability, and salaried GPs may be overlooked with quality improvement. Okay. Data collection, analysis, finding the time. So lots and lots of stuff that we can be thinking about. That these are not unusual issues that people say that they find hard. And we'll tackle some of them. Okay, the next question I want to ask you is, what characteristics or traits would you expect in a leader in primary care? Somebody's saying flexibility in the chat. Cam. This is great. Okay, so we've got able to motivate the team. This is quite a big one. Inclusive. Team builders, diligent. It's lots and lots of different ideas. The adaptability, availability. Excellent. Anybody else before we move on? It's quite nice here about empowering others and teams. Quite a lot of things to think about. Okay, I think that's a good start to get us going. Joanna, do you agree?
I think that's great. It really takes us on to our next stage really well, doesn't it? So shall I go back to sharing my screen?
Yeah, that's great.
So it was really interesting seeing all your contributions there related to how you see good leadership in healthcare, and because actually it's quite a different model from the classical image of some leader who kind of stands at the front of a room and has charisma and natural power and is, you know, just for some reason naturally exudes this ability to influence people, and sometimes by determination and sometimes by the opposite of some of the things that you've been, you know, listing in your description of a good leader. And so I look back and try and see how people who work within this field of leadership and outside of healthcare, most of them have defined leadership, and just to kind of put a bit of challenge to some of the preconceived ideas, which is that Peter Drucker, who's a kind of, any of you who've studied management or business will know all about him. And the only definition of a leader is someone who has followers. But I'm not sure this is fully it, because actually you can have followers just because you command them to follow you. So often we find people who are in kind of high risk emergency situations, for example, in the army or whatever, you basically lead because you follow because you instructed to do so because of huge safety concerns. And actually, when you're leading quality improvement, as we know, that's not the right kind of command and control style of leadership. Often isn't the most effective. So it needs to be more than that. And this guy, Walter Bennett, said that leadership is the capacity to translate vision into reality. It sounds pretty important, translating vision into reality for improvement, doesn't it? because we need to have vision, know what we're going to be doing and try to create it. But this is completely lacking is other people. So you can, you can design a beautiful garden and plant it in a spectacular way and have your vision by the time the summer comes created into reality, but you've not had to lead anybody to do that. You've just done that yourself. So it's not just that, is it? It definitely seems to involve other people leading. You can't do it on your own. And Bill Gates says that leaders are those who empower others, and it was really interesting that you had that as one of your thoughts about what creates a good leader, and I absolutely agree. I think a good leader creates more leaders and not more followers is another quote, not mine. I can't remember who said that one. And so it absolutely is part of leadership, isn't it? Is empowering others, but empowering others to do what? It can't just be that, can it? Because there needs to be a sense of shared purpose as well as you empowering others. You need to have something, some kind of goal, something that you're leading people towards, rather than just being about empowerment. And putting it, another person who's felt they could put it simply, that leadership is influence, nothing more, nothing less. Well, actually, we're all influenced by things that don't necessarily do us any good. So we're all influenced by kind of advertising. People who rioted at the White House, in America on the 6th of January were heavily influenced by someone, but it not necessarily to do anything kind of positive. And so you can also be influenced by coercion. So if someone's holding a gun to your head, you're likely to be influenced to do something that you wouldn't necessarily otherwise do. And so it's not just about influence. And so I think to just pull together some things that you talked about is that you know that it's about empowering others, at creating willing followers and new leaders, that it is about how you relate to others, how do you influence other people. But there also needs to be a purpose, and that the person that leads improvement does not have to be somebody that's in authority. And it's really interesting that some of the things that you said about what was difficult about leading, if you were, say, a partner or a trainee, is sometimes the fact that you feel that you either don't have permission or that you don't have the authority to lead. But actually, we know that it's people who don't always have traditional authority that can have the greatest influence. So you don't have to manage others in order to be able to lead improvement, but you do need to have a sense that you have permission to do so, which I think was one of the barriers somebody highlighted really well. So the giving of permission for other people to lead improvement is actually something that really good leaders do. And so I think that's something that's going to be, I think, pretty important. But they don't have to be domineering or a charismatic individual in order to lead. So I'd love to say that I came up with this quote, but I didn't. This was a guy called Kevin Kruse, who wrote a book called Great Leaders Have No Rules. And he kind of tried to encompass it in one sentence, that leadership is more of a process of social influence that maximizes the efforts of others to achieve a common goal or a shared vision, which I think does have all those elements of good leadership in that. I think I'm going to hand back to Sarah at this point. Now we've talked a bit about leadership.
I don't know, Joanna, if you think that from the answers that our delegates gave us there, do you think that we think differently about leadership in primary care than we used to, or than that we didn't, or that we do in secondary care? Is that fair to say?
Yeah, I think we must, because I was really heartened by those answers, weren't you?
It was really hard.
You get a sense that we are actually valuing the right things in other people. And actually, maybe if some of the delegates on the call today aren't necessarily in traditional positions of authority, they're looking to those people who are and actually seeing some of these things lacking and think, oh, if only you could. Or they've been in an experience where they've felt like they've been led well, and they've been able to identify the characteristics of why that's worked. And that's a good news story.
Yeah, I felt quite heartened by that, because I think I've changed from when I was a junior doctor. I thought leaders were the charismatic command and control types. And I thought that general practice was quite hard to identify who the leaders were, because we were all in our own little castles or our own little buildings. And I think I have evolved into seeing leaders everywhere, GP trainees that can come into the practice and make changes, and even patients can sometimes lead us in different improvement areas. Do you think we need leaders for QI? Do you think we need leadership in quality improvement?
Yeah, I do. I think it's really interesting about how you make change happen, because it doesn't, change happens through healthcare in a whole range of different ways, and it isn't always kind of structured and led. Sometimes just the fact that everyone is, that there's a kind of social thing that can go on where people link with each other as a network of people who are like, the trainees will be talking to other trainees, and then all of a sudden you'll find that practices are doing something different because of conversations that have happened. But when you're doing a more traditional kind of improvement project as such, it's very difficult to make change happen without somebody or a group of people leading that change. So I think good leadership is really important, because good leadership means that you'll have wide involvement as well, because part of that leadership will be about inclusion and collaboration to make people move with you together, and leadership's really important for that. But it's not the only way change happens. I think what we've noticed, certainly looking at the kind of social media networks and how we can be influenced without even realizing how we've been influenced, and all of a sudden we're doing something different, is that that's not always led in a more traditional manner, and it's done through a network approach. But for good quick QI needs good leadership.
I think I echo that from part of my work in peer review. The QI projects that we used to see a lot of doing an audit in your own room and improving something that you've worked on in hours of data crunching, but the rest of your partners, the rest of the practice don't know about it. We used to see a lot of that. And I think the kind of newer ways of working with quality improvement through a much more model for improvement and more robust team involvement and different ways of doing it, you see a lot less of those projects, because there's been some leadership and some attempts to really guide the team through it in a different sort of way.
I think this is a really good place to pick up that question. Actually, it's just appeared in the chat. Somebody's asked, can you kind of comment about ideas for nice projects a trainee can do and simultaneously show good leadership qualities, please? It's a fantastic question. I think traditionally, when I track back to when I trained and we did an audit for our quality improvement thing, and we did it in isolation, and I did a project on how to increase the number of people on thyroxine who had their TFTs done, and it was just about me in a room contacting patients and getting them in, and how that's not demonstrating, well, it's not really demonstrating genuine quality improvement skills, and it's certainly not demonstrating leadership skills.
I didn't realise you were teaching.
Yes.
Oh,
Sorry, my lovely husband. But if you choose a project that's got any degree of complexity about it, you'll soon realise that as you're trying to diagnose what the fundamental reasons are why that issue is happening, and we'll talk a bit about QI tools in a minute, you will realise that you need to get groups of people together to have those conversations, and therefore you will be demonstrating leadership skills. So if I just think of a really simple one, for example, if you're finding that you've got a high proportion of people in your practice whose blood pressure isn't well controlled, who've been diagnosed with hypertension, and you're trying to increase the number of people with good blood pressure control, you can't do that on your own. You need your reception staff, whoever's managing the prescription queries, your nursing team, you'll be unpicking why people aren't, for example, either engaging with reviews, or you'll be unpicking the reason why they're not already got good control. And in doing that, you'll be leading whole team discussions in working out what interventions to test out. So just a simple project like that will definitely be involving leadership skills.
Yeah, and I think the RCGP leadership competencies lend themselves really well to a QI project. The idea of a trainee going off on a leadership course and coming back, I think to actually test and practice and use those skills of diagnosing what the problem is within the practice, what it is that's annoying them, what niggles they've got of day-to-day things that are causing them grievance that they could then drill down into. They're using leadership skills and QI skills to try and solve those problems. So I think I'm pleased that leadership and quality improvement are in the work-based placed assessment for trainees, and slightly frightened that we'll be educating a generation younger with great skills that maybe some of us that have been around a long time don't have as much. But there's no project, I don't think there is a single quality improvement project done well that won't be able to tick the box for those leadership competencies. I think this is a good time to have a wee think about our culture and context. So this is my favourite part of the toolkit that you designed for the RCGP QI Ready. And I think it's something that we don't think about often. We jump into projects, and it's covered really nicely in the book as well. So I'm going to just go back to Menti and share my screen. And I'm going to ask you to just answer this question of where I work, it's called. And this is really, you can use this as a sort of quiet reflective thing if you want to, or you can answer it here on Menti, which is, I'd meant to put this as a scale, but it's actually a ranking. It is the way that it's come out. So looking at, is there enthusiasm for quality improvement? Are you empowered to set the improvement agenda? Are your ideas valued? And part of my reason for putting these questions down was so that we would have the opportunity to think about why this is important. So in our, what we find hard about leadership question earlier, there was a suggestion that quality improvement was maybe not equitable across the different types of general practitioner. And we should maybe have a think about that. Is it different for salaried GPs or local GPs or out of hours GPs? And how do we notice that? And what do we do about that? So again, I'm quite pleased that the majority of you are thinking that there's an enthusiasm, because I think that we can often think about quality improvement as an add-on to our jobs, or as an add-on to our work. Whereas if we think about it, if we reverse that and think about it as being the quality improvement can make our work easier, can make our lives easier, can improve the care of our patients, it's a different mindset. So I'm going to ask you now, Joanna, if that's okay, what is organisational culture and why is it important?
So I think everybody on this call will know where all the different places that we work, as we're training through training as doctors and clinicians, we go through so many different workplaces, don't we? We move from hospital to hospital or practice to practice, and they all have a completely different feel about them. And there are different ways that people interact or are with each other that are unique to that environment. And that is what organisational culture is. It's that sense, that feel, it's how things are done, how people speak to each other. And it is a really important contextual factor to improvement. And I liken it, I think probably the best analogy I've ever heard was that the organisational culture is like this ground that your quality improvement idea or your idea for change is going to be sown into. So if your idea is your seed and you plant it in ground that's just not fertile, it's just not got a culture that's conducive to improvement, you will really struggle to get results from that seed, no matter how many of your best skills you use or your best tools you use. Whereas if you plant it in fertile ground, you are going to get reward. And so that, I think that's the best analogy to what it is. It's a nebulous thing, and business people, as I mentioned before, all those erudite people that we had the quotes from, people have been studying this for decades, and it's very hard to make a single definition, but it is about values, ethos, behaviours, the way we do things around here.
So how would you notice it? If you were a locum or you were a salaried GP or a new partner or a trainee, and you were thinking, I don't know how fertile the soil is here, or I've got a big idea, and how would you notice the culture? What sort of things would you look for?
So certain cultures are more conducive to improvement than others. So those where, for example, hierarchies aren't particularly pronounced, where people see each other more as equals and colleagues and team members, are more likely to get great improvement happening because your people will get that enthusiasm. So what are the things that you might notice that will tell you whether that's happening or not? So if you're in a general practice and you arrive in the car park and there are car park spaces that are specifically for the doctors that no one else is allowed to park in, I think that has told you that there is something about this place that's hierarchical, where some people are more considered, their parking needs are considered to be more important than others. Maybe fair enough if you're a doctor on call or a visiting doctor and to get your car close to the practice, I don't know, possibly, but actually usually that's not needed, and it's a sense of power and importance which is telling you. So that's a really good clue. Sometimes use of, sometimes it's culturally specific too. So I need to be a little bit cautious about this particular one, but sometimes where I find that doctors are always referred to as their title and surname and everyone else is their first name is an interesting thing about hierarchy that might tell you that. Who makes tea for people? So is it only one set of staff that would make cups of tea for other people, or do people do that all together? Do people know when people's birthdays are and do they care? And I saw something amazing on Twitter. I'm probably on social media far too much, but I loved this and I'm going to use it. But it was about cutlery. So somebody tweeted a picture of how do they know that this particular person was in Australia and they'd moved from the public sector to the private sector. And they said, in a single photograph, I can show you that I'm now working in the private sector. And it was a picture of a workplace cutlery drawer full of cutlery. And I didn't actually get that. It took me a while. It was only by reading all the other responses that I recognised that people work within environments whereby the kitchen has no cutlery. Because somebody's decided at some point that if the cutlery walks, which it does because we throw away the teaspoons, don't we? I mean, it happens at home. And when it happens at home, you get new cutlery. You think, where are all the forks gone? Let's get new forks. But in some workplaces, all the forks go and the leaders think, well, you know, people will walk away with the forks and I'm not buying any more forks. And actually, how does that make people feel valued as if they go to get their dinner and there's no fork? So it's just sounds really ridiculous. But actually, these things are really important for people to feel valued. If people don't feel valued, they don't engage. And when they do feel valued, you can get amazing amounts of stuff out of people. So it's yeah, they're the kind of things. Think conversations, what people value, and then forks. Forks and parking spaces.
I think my story about that is not forks or parking spaces, but my first job after I qualified. So after I became a GP, I worked in this great practice, but a really, really big practice. And there was one partner whose door was always open. So you walk past them in the morning and they would say, you know, morning, how are you, blah, blah, and nothing more than that. Really, it was just a greeting and the door was always open and you felt part of that person's day. And as a result, if I finished early, I signed his prescriptions. I took home visits off his list because I was supernumerary. I was like in my induction bit. And you think, I would have presumed the leader of that practice was the senior partner, or they had an improvement team in that practice. But it wasn't. It was the guy with the door open who was just jolly and inclusive and, you know, in his day. So
you mentioned, and going back to the first word count, that our delegates creative listening. He had his door open, so he was there to listen. He was happy to hear what you had to say.
Yeah. And his improvement that year was back in the day before we used centre criterion for tonsillitis. That was his improvement idea, and I can still remember it because he came in and he was, how do we get folk to do this? What do you think? And we had a great chat about it, and he said that was a long time ago. It was 17, 18 years ago. And I think the culture of that practice, you had your scheduled time break. You had a 10-minute slot of non-consulting time to go to the toilet and get a cup of tea, and then you were back in. And I probably noticed his friendliness more because it wasn't in the same way. Okay, so next question is really hard. How do we influence organizational culture?
It is hard, and I think it really picks up nicely on, we've had a question in the chat as well about if you feel that people won't share that kind of story, their stories with you, they're not, you're entering an organisation new where people don't talk about what's going on in their home lives, and you don't know when their birthdays are. You're basically entering a culture that's not necessarily yet very conducive to improvement. And it's hard to influence, but you just get started on it usually by giving a little bit of you, because actually people really like to share their stories, but they often, if they're working within a culture where they're not used to ever being asked about stuff, they won't naturally volunteer it. I had this lovely kind of magic moment in my practice a few months ago when I came in and our ST2 was already in reception. And the conversation he was having with one of our reception team just made me glow. You know, he'd clearly shown a real interest in her, and so by showing an interest in her, she would then, you know, she came to life. She was really talking about what was going on for her at that moment because he was curious enough and interested. So sometimes it's about being happy to ask and being happy to share yourself, and you can make they feel like little tiny things. And you know, if there's no forks in the drawer and you come along with a load of forks, oh, wouldn't it be great? Let's get some forks. It sounds ridiculous. Making a cup of tea for someone, so going in the afternoon and saying, "Does anyone want a hot drink?" They feel like really small things, but actually, I have known trainees make magical differences, or new members of the team or salaried doctors creating magic with just smallest things. And I remember, for example, a trainee that used to have a very busy home life and had to get kids to nursery and stuff. So they always arrived at work a bit early and had their breakfast at work, standing in the kitchen while people arrived and were hanging their coats up and having a cup of tea. And that bit of chat influenced the way people thought and felt. So small things can raise people's team feelings. And I know, you know, for its sins, WhatsApp, we've all got bombarded with WhatsApp, haven't we, over lockdown and been in far too many groups. But actually, if I think back to the early time in the pandemic, those small social how are you feeling stuff in group WhatsApp groups actually made a difference to culture, made people feel they were looked after and that they were part of something bigger. So they're the kind of things that I would do. That sometimes, if you've already got a culture that's pretty conducive, then they're already there and ready for it, and that's easy. But when you're coming in and it seems very closed or very, very hierarchical and people aren't talking and not meeting and not sharing, then you feel like there's very little you can do, but even a very small thing can go a long way.
I'm just going to pick you up on that, if that's okay, because I think COVID is the best thing that happened to my practice in lots of ways, because we split the whole team. So we were like, you're the morning, you're the beginning of the week, we're the end of the week, and we'll never be in the same room in case we get unwell. We've got a functioning practice. And then we were like, but I miss you. Like I miss seeing you and talking to you. And without that enforced rules, I would never have known. I would have never have known that that's the way that we felt. But we communicated so much better than we ever have done, because before COVID, we would wait for the opportunity of when we get 5 minutes, when we get 10 minutes, we'll make sure we talk about that thing. Whereas we've sort of moved to a bit more electronic communication. So for the partners that are not in on the same days, there are Teams meetings that are, so we've managed to just improve our overall communications by having to think about it, having the break to think about it. And when I think about the number of practices I've worked in where the doors are closed, where there's some partners or some doctors that you just don't really know, I would be curious to know what COVID has done when we've all had to come to work differently. So we've done a wee bit about how you would notice the culture. We've talked a wee bit about how difficult it is to influence that culture. My next question then is how would you know that the culture is ready? You're ready for change. How would you notice that?
So you know that you've got something right if you suddenly find that wider members of your teams and not the same people who always have ideas, start to come up with ideas. They've always had them, but there was something about the culture maybe before that made it, or about their own confidence possibly, that made it difficult for them to share those things. So they also, especially if you've used a lot of kind of improvement methodology within the practice so that people are, they're used to the way that you might normally change things, they might start to say things to you like, can we try this out? So and I'm sure you've covered this on other webinars, and any of you that have training in quality improvement know that one of the really fundamental things with quality improvement is that you don't arrive with a preconceived idea about what's going to make the difference. You instead have a number of interventions that you test out. And so when people say, use the language like, oh, I suppose we could try that, then you know that you've developed a way of thinking that is really conducive culturally to improvement. And I think anyone that's ever seen me talk knows I'm a big fan of measuring stuff, and I think measuring is pretty important in QI, most projects, to know whether you've made a difference. But so when somebody says to you, oh, can we find out how many times that happens? So say if something's gone wrong, if an error's happened, if something's got lost, if prescription's not ready for a patient, and somebody's thinking, God, I wonder how often that happens. Should we count it for a week, or shall we? Then that's a major clue that people are into that, yeah. Or you get some clues that they're curious about why something happened. So I've noticed if I'm observing in reception, you might get two equally lovely reception team members, and somebody comes to the desk and says, I booked this appointment and it's not there on screen, or something's gone wrong. There's one team member that might go, oh, I'm really sorry about that. Let's sort it out for you. Which is great, brilliant customer service. The other might do that equally well, but then say, well, just remind me, when did you book it? Did you do it over the phone, or did you do it over online? And they're immediately going into QI diagnostics.
Yeah.
So they're thinking, I'm just worried about this happening again. And I had a magic moment with my reception manager, who was really drilling down something last week that hadn't gone. We use medication review dates kind of religiously as our way of doing safety. And somebody was on a repeat prescription and there was no review date. And she was, watching her try to work out how that review date had disappeared. And she went, I just want to, because if this happens a lot, we'll be, everything, all our systems will go to pot. So she was that curiosity thing, and they're the clues that people are ready. And of course, to reach that stage where they're curious about that, all that groundwork that you need to do first to listen to them, to make people feel valued, to make people with ideas heard, is, that's going to reap those rewards for you.
That's great. And I think, again, for this sort of, to make it useful, to make if there are trainees on this call, and there's another comment in there about the load of the ST3 year with new exams and so on. I think that's a really marvelous idea of just paying attention. What are people, what do you notice? What are people doing? What things are troubling them? How are they managing to drill down into those areas about lost prescriptions, or about the workload or appointment systems? We can't come in with a next door, do it this way. I've got a great idea. how, you know, let's change everything tomorrow. And we're a wee bit prone to that as doctors. We're a wee bit prone to jumping in with the solution. Now, I've seen this work elsewhere. Let's.
And Sarah, I don't think it's just doctors. I think we are very solution focused, and we love other people's good ideas. It's why we're also susceptible to advertising, and we end up wearing the next new thing or whatever. You know, we like that. We like there to be an answer that someone else has prepared. Because that would be really easy, wouldn't it? I could just buy that. And then our context is so unique, full of different individuals, and then we might get cross because it's not working here and it works there, because we haven't done that initial diagnosis, we haven't understood our own context. Or so yeah, absolutely crucial to think, what problem is it we're trying to fix with this amazing new idea, rather than let's just implement this amazing new idea.
So with that in mind, we don't have time to go through every leadership tool or every leadership technique or every QI tool. What do you use most often? What's your go-to things that you use for leading a project or for getting a project over the various hurdles?
My favourite tools are definitely those that we use to diagnose the problem. And that's for a number of reasons. One is because I think that bit's really important, and because sometimes you don't, and this is not helpful for the people who prepare work-based based assessment, because you need to be able to look at all the different stages, but sometimes when you thoroughly unpick the problem, it solves itself. You might not always need something else. So that's one of the reasons that I like those best, and I'll tell you which ones. But the other reason I like them best is because they're often very collaborative. So when you're leading improvement, you need everybody to be on the same page at different stages, so that you are working together on something. And if you start with your diagnostic tools that everyone's doing together, then you'll bring people along with the rest of the plan. So for example, process mapping, people will probably have heard of, but when you're trying to look at a complex process, like how do people get a repeat prescription, how do they access the practice or book an appointment in the old world, or how do you do a referral? And there's lots of different stages in that process, and there's lots of different people involved, and each individual person is unlikely to know the whole story. So if you get together and map out the current state so that people can together work out which bits are working well and which bits aren't working well, I would call that the art of thinking together, because you're coming to the same kind of conclusions at the same time. And those tools are lovely for that. And so things that unpick problems. Sometimes doing fishbone diagrams, it's a tool that it's a bit more of a complex tool, and I wouldn't expect everybody to have necessarily experienced it, but you're basically looking at all the factors that mean something doesn't work. So if we use the example I had before about why people's blood pressure is not to target, and if you do that as a team where everyone can think of all the potential reasons, and again, that's thinking together. You're really then unpicking something as a collaborative effort, which is it's great for people who want to be demonstrating their leadership skills in getting people to have those conversations. But those tools I find incredibly useful. Sometimes measuring for diagnostic purposes, so like I was saying, how many missed prescriptions have we had this week, where every member of the team gets to put a tally on a tally chart when they couldn't find one. And that's actually very collaborative in that it makes people feel listened to. So if they've come to you as somebody with a leadership role, or somebody who wants to lead a project in the practice, and the decision's been that you're going to reduce the number of lost prescriptions, and you're going, right, well, okay, tell me how many it's happening. It's a real sign that you're listening. You want to know. So those tools I really like for that.
Yeah, I agree. I use the fishbone diagram surprisingly often, because it is one of those ones that you just draw and you almost have your back to the rest of the team. So you're not, quick, let me write it up as you speak, and people can sort of collaborate quite easily. And often there's people that you wouldn't hear their voices otherwise, because you wouldn't interrogate that part of the system unless you've asked them to contribute to something like a process map or a Fishbone. So
on that about unheard voices, actually, do you mind me?
Yeah.
Because it was in one of the earlier Mentees when people said, you know, how motivating, engaging others, and often when people are very quiet in meetings, we can interpret that as being that they're not motivated, and sometimes that's might be true, and sometimes it's because people aren't used to having their voices heard or hearing their voices in a group. Because even if you try and eliminate power and hierarchy, there are still people who feel that their contribution won't be valuable and they might struggle to say it. So if people haven't come up with anything, it's usually not because they haven't got anything in their heads. It's because they don't feel able to share it in the way that we, as doctors, we often hands up. We've been used to doing that and processing things verbally. So often there are the other kinds of tools, which are those about facilitation rather than necessarily about QI, that can be really helpful, and I would say get used to leading those. So you get people in pairs and they share their ideas and they write them down on a post-it note, and then it's a shared joint idea. It's not owned by a single individual, so they feel more confident. They've not had to speak it, they've written it on a post-it which they can give to the leader and then they can speak it. So those kind of techniques that are really important leadership skills are incredibly useful for getting voices heard.
Yeah, that's a good point. I'm glad you raised that. We've got an interesting question here from one of our audience that says, how is leadership in QI different from leadership in general in primary care?
It isn't different. It's just when you're leading improvement, you've got a very specific purpose, which is making something better, and then we have a set of kind of useful improvement tools, which if you're leading QI, it's helpful to have a bit of an understanding of. But the actual general things, it's when you're leading something, you generally, actually, most leadership is about improving stuff. Otherwise, it's just mostly management, day-to-day management of things. Not that you don't use some leadership skills when you're managing people and processes, but generally, leadership is about improving and making things better.
I think we can all lead an improvement project of various sizes. You know, everybody could be in charge of or lead small improvements or giant, big across the PCNs sort of improvements. We're running out of time a little bit, but I want your top tips on how you deal with the non-engagers, because that came up earlier. You talked about motivating staff, but what about the heel draggers and those sorts of team members that are not keen? Any top tips for what you do with them?
I think somebody said it beautifully about listening in the earlier about what good leaders do, because we often make assumptions about why somebody isn't engaged in it, and we rarely actually try to find that out. And there's often a number of different reasons, and it may be that actually other aspects of their work are already overburdening them, and there is a sense that they cannot cope with one more thing, and that might be because workload within the practice is what's causing the problem, or it could be that there's multifactorial, that their rest of their life is actually a bit too complex at the moment and they need simplicity in their working life. And actually, if that's the case, that's fine, isn't it? You and that's very different from somebody who might be actively resisting. So if you get a sense that there's somebody in your midst that seems to be trying to scupper what you're doing and actually sabotage it, that is a very different thing from just, I don't have capacity for this at the moment. And plus, then there are other reasons. So there are people who might think that that's not their improvement priority, or they wouldn't have chosen that thing, and it doesn't particularly interest them, in which case that's a different skill altogether. That's about starting with the why. There's a wonderful book by Simon Sinek called Start With Why, which is basically tells you whenever you're working with teams, unless you can articulate why you're wanting to do that thing, how can you expect anyone to climb on board if they don't know why? So sometimes that's about the why. So working out why they're not engaging is important. The sabotagers are interesting because they might be seen to be being sabotaging, but actually, and I know this because I know doctors particularly do it, they worry about all the things that might go wrong with that project. So they out clever it, and it can come across sometimes as being overly negative or resisting change or sabotaging it, because they can't do that thing that you've suggested, because this might happen and that might happen and that might happen. And actually those people can be incredibly useful. You should value those people, because when you're leading improvement, I can be guilty of this, of being overly optimistic and forgetting the things that might go wrong. And when we're leading improvement, we need to think about what might go wrong, so that we build in measures for that, so that everyone's looking out for that thing, because it has to be balanced. Those in QI data and measurement tools, I think you've got a webinar, haven't you, coming on in soon. We have different types of measurements in QI, but one of those measures is called a balance measure, and that's looking out for the things that might go wrong. And those people who might come across as being resistant to change actually are the people who might come up with your balance measures, and then they feel listened to, because that thing is being looked out for, and they are less likely to sabotage or to stand in your way, because actually they then become intrigued. Also, the language of QI, where you're not coming and saying, we're going to do this idea and it's going to work. When you're leading improvement and instead you say, I'd like to improve this thing, and these are my possible ideas that I'd like to test out, or we've all come up with some ideas to test out, that is much more engaging than you coming and saying, we're going to do this and this is what the outcome's going to be. So the language of improvement, of testing things out, looking out for balance measures, can really help you to bring people in who don't traditionally do that thing. So articulate the why, appreciate those who just might not have the headspace for it at the moment, and make best use of your overthinkers, the people who might look like they're standing in the way. They would be my tips.
That's great. That's a great top tip. I'm going to move back to Menti now. So I'm going to share my screen again. And she says, and the next question that I want to ask on Menti is, what's everybody else's tips for changing the way things are done around here? So top tips for getting that change, and I'm going to put down using those people. That's I think I'm probably one, and a lot of the time, that you worry about, but what if this ends up causing us? So that's great to just have a think about it. Somebody's asking a question here about trying to be collaborative, and this participative approach is obviously usually the best, but if it doesn't work, should we maybe have a bit more of a hierarchical kind of command and control in the interest of the organisation? Is there ever a time that you switch your leadership style into a bit more, a bit more of a command and control, or a bit more hierarchical? What do you think?
Crises, emergencies, definitely very different. It doesn't mean that you can't be kind, be compassionate, be nice, all those lovely things, but actually sometimes people are looking to somebody to take control. People will know this from when they've ever kind of gone to an out of practice or hospital collapse, or somebody, they're looking for someone who says they're a doctor or they're a nurse or whatever, because then everyone's going, oh, thank God for that. And actually they want you to just tell them what to do at that point. And I think this was particularly noticed very early in COVID, wasn't it? When you needed smaller groups of people who just said, right, well, there's loads of guidance out there, and you read that, you read that, you read that. We'll come together, tell us what to do, and we'll do. How are we going to do? Do we do a perspex screen up at reception? Do we do do we lock the door? So there needed to be fast decisions made in a crisis, and as long as everyone is still doing a degree of collaboration and listening to each other, somebody needs to take control. And I think clearly the military are really good at that. They have a very structured leadership style, so that people will do, in a crisis situation, they would just line of command, they'll do what they're told. Really good place for it. Fortunately, most of our lives aren't like that. So.
No, and I think actually in a crisis, when we lead like that, it can just feel like a crisis all the time. It feels, and then you get people that just start rebelling a little bit, or not towing the line. This is great. Our top tips: a lot of positivity, and a bit about not being afraid to try something and fail. I think that's a very positive way of looking at it. So I'm going to move on.
I was a lovely improvement quote for that, which is sometimes I improve and sometimes I learn. So we try not to see it as failure. It's like, oh, I learned what didn't work. That's great.
That's good. Okay, so we're just going to ask you to put up some take-home messages, and then in a few seconds I'm just going to get Joanna to share the very last slides about our resources. I'm aware that we can't really teach the various QI tools, but I hope we've given you some insight into the different sorts of QI tools that we can use for leadership as we go through. And there is great resources that we're going to share with you for if you're wanting to do a fishbone, if you're wanting to do a process map, having a look at it before you do it, and then giving it a go. And I think a lot of what we talk about is having the team on board, so that they'll come with you for that. Just done something odd to our results there. Sorry, I think I've just accidentally deleted them. So if I move to the slides, is that okay, Joanna? Can you share that? I think that's a great one. That take-home messages about active listening is the key, and really noticing. I think really noticing what's going on. That's great. So these links to the past webinars, the one that says Introduction to QI Methods, that has a run through of process maps, fishbone diagrams, force field analysis, and just the sort of how-to tools. And beyond contractual QI has a little bit about behaviour change at the end. And these two at the bottom, the QI resources, they have something called a quick guide, where it's a sort of one pager on each of the tools, and it would be might be useful for you in your next sort of projects. And I'm just going to, it's one more question quickly. Are you able to share the slide yet? So this slide will be shared with everybody. And these links can be accessed then. So thank you so much for joining us tonight. It was great to talk to Joanna. I could talk to you all night, I have to say. I learn so much every time I talk to you. And if there's any other questions or anything, please don't hesitate to get in touch.